to be very nice. Dr. Diane Spicer is showing live some specimens of heart. So this series is being each time better. So I hope all of you can join. Please join our social media on YouTube, especially because there you can find all of the meetings that we already have. And if you like this meeting or any other of the meetings that we already did, please share the link with your colleagues. And I'm sure more people can learn from these amazing experts that are talking to us. 1st of April, Dr. Gil Vernovsky is going to continue his CICU series. He's going to talk about clinical research. This is going to be awesome. And on April the 6th, we have this pediatric ECG series from Dr. Volkan. This being very nice, it's very practical, and he discusses a lot of ECGs. So please join us. This is only 45 minutes, but it's really worth it. We are going to have in April, Dr. Silverman talking about petrology of Fallot, Dr. Mary Cohen talking about coronary artery anomalies. And during the month of April, Dr. Anderson is going to continue his series with Dr. Diane Spicer as well. So now I want to introduce to you Dr. Rima Badr. She is a professor of pediatric cardiology and fetal cardiology in Saudi Arabia. And she is the leader of this fetal series. And we are very thankful to her that she's placing this series together. This is the third meeting that we have, and we have a big webinar before these 3 meetings, and we are going to continue every last Thursday of the month with the fetal series. Thank you, Rima.
Thank you, Grace. Welcome everybody on board. I'm so grateful to Congenital Heart Academy for giving us really the chance to sort of spread the knowledge with world experts in fetal cardiology. We're also so honored to have a group of Brazilian specialists talking about fetal cardiology today. And as we know that every last week of Thursday, we're going to bring you an updated sort of courses on fetal cardiology. And who wants to introduce the first speaker?
I will introduce, so we are going to start with my dear friend, Gustavo Fávaro, and he helped us to place this amazing speakers together today. Thank you, Gustavo, for that. So Gustavo is the coordinator of fetal cardiology and echocardiography of Sabará Children's Hospital and Beneficência Portuguesa de São Paulo. He is PhD in science at University of São Paulo, and a very close friend of mine. I'm very happy to have him here.
Thank you, the organizing committee of the Congenital Heart Academy, for the invitation. It's a great pleasure to talk about fetal echocardiography. I really enjoy this topic, which is part of my daily practice. We'll kick off with the first talk on how I do fetal echo and the steps I go through while scanning. I have no disclosures. First off, it's worth emphasizing that during the embryogenic stages, the achievement of a normal heart is a miracle. Why? Because it's developing extremely complex and early in life. The heart usually completes its formation at 8 weeks of pregnancy. Perhaps that's why congenital heart disease is the most common congenital malformation, and a normal heart, it's a miracle with no doubt. In search of confirming this miracle, fetal and pediatric cardiologists use something systematic, clever, and efficient. That is the sequential segmental analysis, such an approach that helps us a lot to diagnose the most complex heart disease. And I'm sure that is not a new concept for anyone in this audience. However, in fetal life, we do the approach differently. We often do not obtain all views sequentially or all of them, making the analysis more challenging. We should always keep in mind during the scanning the views we are going to perform and the views that are missing. I keep a checklist in mind of what is needed to confirm normality and the views that need to confirm it. I try to obtain 4 positions of the heart in relation to cardiac anatomy and the alignment with the probe. Following this concept, I do my assessment of fetal heart with the heart upright, lying down, long axis, and short axis. As you know, there are several guidelines of fetal echocardiography, and its learnings are so important in our daily practice. Let's talk about a sequence of actions while performing fetal echocardiograms. We first focus on confirming that it's a normal heart. If there is any suspect abnormality, we open our checklist and proceed the steps. After diagnosing any abnormality, we make the action plan, which consists of counseling, follow-up, birth, and postnatal care. Here it's an example of a checklist that will open your mind if you find an allosystolic tricuspid regurgitation, and we have to exclude each one of those. Before starting the exam, we check background, gestation age, exam indication, and pregnancy history. Let's go and start the best part. Cardiofetal preset is selected, confirm a fetal position, obtain a wide view of the heart. The stomach is then confirmed to the left, and the relation of a normal cardiac area to the chest, a normal cardiothoracic ratio. The routine is confirm the normality of each cardiac structure, so we'll be able to exclude heart disease, thus the heart would be normal. As you can see, the aorta is on your left and inferior vena cava on your right, confirming that IVC drains blood into the right atrium. On performing this screen, you confirm cytosolitis and exclude heterotaxias and cytos inversus. First position, heart standing upright on the screen. We know that an efficient scan is essentially when we access on a bidimensional way a structure that is really three-dimensional. Starting from the posterior extremity of the heart, and we sweep to anterior extremity in the next slides. We visualize a normal-sized coronary sinus on the left. It is known that it's an important information for cytosolitis. We also see normal intercavitary flows, excluding coronary sinus pathologies, APVC, PLSVC, fistulas. Sweeping the transducer in cranial direction, we visualize a normal left atrium. It isn't bald, expression that we use when there is no pulmonary venous drainage to the left atrium. Also, it isn't small, and the descending aorta isn't away from the heart, which would lead us to think about a venous collector between them. So we rule out total anomalous pulmonary venous drainage and core triatriatum, the heart defect that essentially means heart with 3 atria. In the same view, atrioventricular valves have normal features, insertion, and function. There is a normal offsetting as the mitral valve is just above the tricuspid valve. I meant the tricuspid valve is normally apically displaced and exclude AVSD, abstain, valves dysplasias, hypoplasias, and entrasias. Keeping the same view, please check cavity size and position. Right ventricle has a moderator band, thicker trabeculations, trabecular portion is present in this one. Normal biventricular contractility without effusion around the heart and the regular contour of the heart silhouette. We exclude all of those defects aforementioned. Tilted upward, we open a first outflow tract that connects with the left ventricle. This artery is more tubular and triangular shaped vessel, which make us to think that it's aorta rather than pulmonary artery. The subaortic portion of the interventricular septum has no discontinuity, and there is no overriding of this artery on the interventricular septum. And we exclude aortic stenosis, aortic regurgitation, membranous VSD. As we go farther, it is the moment that we margins have such a good relief, as we visualize the presence of another outflow tract that is crossing one another. The anterior artery is more triangular, has an early bifurcation, and no abnormalities on color Doppler. Exclude TGA, CCTGA, FALO, DORV, pulmonary atresia, truncus. Also, anatomically correct malposition means that despite the abnormal relationship between the great arteries, the aorta arises nonetheless above the anatomically left ventricle, and the pulmonary artery originates above the anatomically right ventricle, as Professor Van Praag first described on Circulation Journal back in 1975, and it's also excluded. In the three-vessel and trachea view, we visualize the normal sequence of vessels, pulmonary trunk, aorta, and superior vena cava. The proportion of vessel diameters from largest to smallest are maintained, excluding, even partially, coarctation, interrupted aortic arch, FALO, APVC. Continuing with the heart standing upright and in a view just by the 3VT, we are able to see the two pulmonary branches as well as the arterial duct. And I love this view, excluding restricted ducts and aortic origin of right and left pulmonary artery. Going a little further, normal aortic isthmus just like aorta on the left of the trachea. The absence of a vein below the pulmonary trunk rules out persistent LSVC. We exclude also vascular rings, coarctation, interrupted aortic arch. Look at the normal size and flow of the brachiocephalic vein, which is also far from the sternum. Therefore, it's a sign of the absence of aplasia or hypoplastic thymus, excluding even partially George syndrome and supracardiac APVC. Finally, for this heart position, observe the right subclavian artery on the right of trachea. Exclude aberrant right subclavian artery. Moving to the second heart position, lying down heart. With the heart lying down and sweeping from the posterior edge in a caudal direction and then up to 4 chambers, we visualize a fossil-vallis ASD not very wide and central that seems like a good membrane for postnatal close, without discontinuities of the upper or lower atrial septum. Normal left atrium with normal veins drainage, ruling out a small or bald left atrium. Also normal atrioventricular valves offsetting and descending aorta next to the left atrium. Exclude APVC, carotid atrium, some ASD, AVCD, absent valve dysplasias, hypoplasias, and atrasias. Also, we can see no communication in the ventricular septum, regular sternum heart silhouette, normal ventricular cavities, absence of cardiac masses, normal function, normal pericardium. We exclude all of those pathologies aforementioned. With a little sweep, we get a great view of pulmonary veins and the interventricular septum, excluding APVC, perimembranous VSD. At this stage of scanning, we are relieved again. Crossing arteries, the first is tubular and the second is triangular shaped. The first artery is anteriorly located at the early bifurcation. Exclude TGA, CCTGA, or aortic stenosis, aortic regurgitation, aortic LV2 tunnel, anatomically correct malposition. Now we assess the pulmonary valve and RV outflow tract, excluding tetralogy of FALO, pulmonary stenosis. Tilting upward, the 3VT is angled parallel to the Doppler interrogation. We can exclude coarctation, interrupted arch, vascular rings, PLSVC. This is the view of pulmonary branches and ducts, which help us a lot to assure arteries normality. This view also provides information of arterial ducts. In the same sweep and getting to the end, the right subclavian artery is now viewing another unfavorable view to Doppler alignment. I hope you're enjoying. This third view is very similar to the previous one, but bring us up some advantages. We gotta rotate the probe mark around 30 degrees in relation to the previous view, rotate clockwise or counterclockwise. You will move the probe accordingly falling fetal position. In this case, we first tried one side. If it doesn't work, then you move to another side. A great left ventricle outflow tract. Normal ventricular septum, normal aortic valve, a good view of the ventricles. Such a good relief again, two arteries crossing themselves and in correct positions. Now sweeping in order to get great alignment on Doppler. Exclude coarctation, vascular rings. Getting close to the end, the last heart position from the previous view, rotate 9 degrees to obtain short axis view. In this view, we access again very well the ROVT, also the pulmonary valve, and if there is any communication between the ascending aorta and the pulmonary trunk, we should be able to see. In these videos, the pulmonary trunk has no narrowing or flow acceleration, and also the aortic valve seems to have 3 cuspids. Sometimes you may be able to identify some coronary arteries anatomy. Exclude ROVT obstruction, pulmonary stenosis, pulmonary regurgitation, aortic pulmonary window, pulmonary supravalvular stenosis, bicuspid aortic fistulas. In caudal direction, we get a short axis view to evaluate the interventricular septum from different perspectives, and the mitral valve is seen cross-sectionally, excluding VST, mitral parachute or arcade mitral valve, RVOT obstructions. From the short axis, keeping the transducer slightly tilted and moving along the maternal belly, searching for the spine longitudinally, then we visualize the aortic arch. Performing a wide sweep, we exclude the presence of any anomalous vein, regardless of being pathological or not. We exclude coarctation, APVC, infra and supra, azygos, and hemiazygos. I would like to conclude by saying in this same view, and with a light sweep about 10 degrees, it's possible to access the ductus and the RPA, excluding that the LPA does not originate in the RPA. Assessing all of these plans and positions, we avoid false negatives on fetal echocardiograms, and we offer the opportunity for efficient treatment in children with congenital heart disease. In this one, we excluded restricted ductus and pulmonary arteries link. We also exclude arrhythmias, topic that Claudia will speak soon. It's a great pleasure when I say to the parents that her child's heart is anatomically normal. At least there are no heart defects supposed to be diagnosed before birth. Many of our limitations and mistakes are due to trick images, especially when you have poor image quality. As in the TRIVT view, an image of a TRIVT in a fetus with TGA doesn't exist and sometimes could be visualized. Usually it would be part of the roof of the left atrium, or we are scanning too close to the pulmonary valve. Therefore, I think it's so important to pay attention to the continuity of the structures and to the correlation of the image with and or without color Doppler. And we have to use the technology as it is developing to our best results. Thank you for your attention. I'll be happy to take any question.
Thank you very much, Gustavo. It was amazing. Rima, I think you're going to introduce the next speaker, right?
Thank you very much, Gustav. That was a beautiful introduction to fetal cardiology and what we should do when we do a basic scan. And you nicely sort of wrapped up everything in a way, and beautiful images. Thank you very much. We will keep the questions till the end to give our audience a chance to think about it. Our next speaker is going to talk about fetal heart failure. And this is Dr. Simone Pedra. She's the head of pediatric and adult congenital heart disease and director of fetal cardiac program at HCor Hospital in Brazil. And we're very grateful to have her on board. Please. You're on.
Okay, let me just share my screen.
Yes, you just unmute yourself if possible.
She's unmuted. Yes, we can hear you.
Yeah,
yes.
Okay. So I'd like to thank the opportunity to be here and to participate in this great webinar, and thank Grace and Gustavo for the invitation. And my topic will be on fetal congestive heart failure. I have no disclosures. And the definition of fetal congestive heart failure is inadequate tissue perfusion for normal organ development and function. It's a final common pathway for all fetal disease states that lead to fetal demise in utero. Before talking about that, we have to remind some particularities of the fetal circulation. So both ventricles pump to blood in parallel, and the high pulmonary resistance. The right heart pumps to the inferior part of the body and accounts for 2/3 of the cardiac output. The left heart pumps to the superior part of the body and accounts for 1/3 of the cardiac output. And the low ventricular compliance and the foramen ovale is the communication between both atria, and the aortic isthmus is the communication between the ventricles. So the cardiac output is the product of stroke volume and heart rate. So everything that may interfere in preload, afterload, contractility will interfere or diminish the stroke volume, or heart rate will have chance for congestive heart failure, like twin-to-twin transfusion fistulas, high output fistulas that interfere in the preload, right and left obstruction lesions like ductal constrictions, intrauterine growth retardation will interfere in the afterload and stroke volume. The cardiomyopathies will lead to low contractility and will reduce the stroke volume. And the tachy or bradyarrhythmias that will have its role in heart rate. The final stage of fetal congestive heart failure is increase in left and right and ventricular, right and left ventricular and diastolic pressures, increase in right atrial pressure and central venous pressure. And with that, associated with low oncotic pressures in fetal life and diminished lymphatic drainage, will culminate with effusions and edema, which is called hydrops. There are many causes that will lead to fetal congestive heart failure, and we divide in cardiac and non-cardiac causes. And here we have a list of some conditions that are not structural, and what they may lead, the consequence that this kind of condition will have in the heart. So maternal diabetes, we can have cardiomegaly, hypertrophy, diastolic dysfunction, intrauterine growth retardation, we'll have RV dysfunction to increase the afterload, teratomas, a cardiac twin gestation, galenovein aneurysm, we have high cardiac output states, the twin-to-twin transfusion syndrome, cardiomegaly, hypertrophy, systolic and diastolic dysfunction. We can have extrinsic compression like diaphragmatic hernia, cecum, Anemia and myocarditis are all known structural conditions that may lead to cardiac dysfunction and congestive heart failure. And we have also cardiomyopathies, fetal arrhythmias, and cardiac tumors. Those are all cardiac causes, but not non-structural. And the structural malformations that compromise the fetal cardiac function and can lead to congestive heart failure are critical aortic stenosis that lead to EFE, systolic and diastolic dysfunctions, mitral regurgitation, and finally LV hypoplasia, pulmonary atresia, intact ventricular septum, EFE, systolic and diastolic dysfunctions, and severe valvular regurgitations like absent pulmonary valve, Epstein anomaly, and tricuspid valve dysplasia. These are the main causes of structural diseases that lead to congestive heart failure. Well, when we have to start our echocardiographic assessment, we have many items that must be fulfilled, and we can start with the cardiothoracic ratio, the heart size, and then systolic function, diastolic function evaluation, valvular regurgitation, venous Doppler pattern, and if the presence of effusion and edema. So starting with the cardiothoracic ratio, we have two ways of doing it. We can do the area ratio or the diameter ratio. When we are talking about area ratio, we use the normal would be 1/3 or 30%, and the diameter ratios, the normal ranges would be 0.5. There are some, for myocardial function evaluation, we have some challenges in fetal cardiac function assessment because of the features of fetal circulation and because of the small size of the heart, the high heart rate, and the distance from the fetals from the transducer. We can use many techniques to evaluate the myocardial function. And talking about systolic function, we can use the eyeballing, shortening fraction, fractional area change, cardiac output index, the DPDT in the presence of valvular regurgitation. We can use TAPSE, MAPSE, tissue Doppler, and the global longitudinal strain in some instances. So let's start with the eyeballing. This is a critical aortic stenosis, and everyone can see that this LV has a severe dysfunction. We don't need really to calculate any index. Looking at this LV, we see there is a severe LV dysfunction. And after the procedure, we can see how this LV improved. So this, without doing any index or any method, we can see that this LV has a durable function. And then we can use the shortening fraction. And this can be done either employing the bidimensional mode or the M mode, as we see here. And everyone knows the formula to do that. So we can use measurements, the diastolic measurements, the systolic measurements, and employ the formula. And another index that can be used, we can assess the RV function using the TAPSE or the LV function employing the MAPSE. And we can calculate the systolic function, the cardiac output. And the cardiac output, we can use the outflow area and VTI and do employing the formula and get the cardiac output and the cardiac index. We can employ here, this is a tissue Doppler of fetus, and this is the S-line wave. And here an example of two vendors of the global longitudinal strain to assess the myocardial function. This is an example of one of our case. This is a pulmonary atresia with intact ventricular septum. This is the RV global longitudinal strain is minus 3.5, and the LV with its normal function with a strain of -15, as you can see here. To assess the diastolic function, we can employ many other like post-Doppler AV valve tools, like post-Doppler AV, and we would evaluate the AV valves, the pulmonary veins, the systemic veins like IVC, hepatic veins, ductus venosus, the umbilical vein, the tissue, and we can employ the tissue Doppler. And there are some other indexes like the left atrial shortening fraction or the septum primum exclusion index. Here we can see some of the vein Dopplers. So this is the left hepatic vein. This is the normal tracing, the IVC flow, the ductus venosus, and we see that the A wave is positive, and the umbilical vein. And here the AV valve, the normal AV valve tracing with E to A ratio, with a low velocity E related to the A velocity. And this is the E to E ratio. This is the tissue Doppler. And here we can see how they change with the diastolic dysfunction. So this is a mild diastolic dysfunction. This is the AV valve. You see the difference to the normal ones. And when we have the severe diastolic dysfunction, we have a single wave with very short time of inflow. The IVC flow, you see, is still triphasic with SD and a deep A wave, and here a biphasic flow. And in this ductus venosus, we see diastole, zero diastole, and here the reversed ductus venosus flow, A wave. We can use the T index, and we know that when it's greater than 0.5, it's abnormal. And the T index, everybody knows that we use the inflow and the outflow, and it's the ejection, the contraction time, and divided for the ejection time. And we have to employ, when we are assessing a congestive heart failure, the cardiovascular profile score that was published by Dr. James Utah. And this is a score that uses 5 different items, and including high drops, venous Doppler, the heart size, the cardiac function, and the arterial Doppler, the umbilical artery Doppler. And we know that normal is 10 points, and when it's below 5, there are high chances of death. So it's very important when you are assessing a congestive heart failure to do the profile. I'll show some of our cases. This is a fetal dilated cardiomyopathy, and we see here very bad function and severe AV valve regurgitation, mitral and tricuspid. And here, how the inflow is one wave only, and very short time of inflow, and the holosystolic regurgitation. This is a tetralogy of Fallot, an absent pulmonary valve. We see here a huge heart, the flow, and for the flow that the regurgitation at the valve, the severe dilated pulmonary arteries, and you see here the ductus venosus with zero diastole. And here, this is a case of Hebstein anomaly, and you see how big is the heart and the severe regurgitation. And this is one of the cases that can lead to congestive heart failure. Another case, this is a pulmonary atresia, intact septum after fetal pulmonary valvuloplasty. Unfortunately have a circular shunt, and you can see the edema here. You can see fluid, the ascites, and pleural effusion, and you see reverse ductus venosus, and the diastole 0 in the umbilical artery. Here, pulmonary insufficiency, severe, and low RV pressure, reverse ductus venosus, and in this case, very severe circular shunt, and you can see diastole, reverse diastole in the umbilical artery. So they are all very important features of congestive heart failure. We have here a genesis of ductus venosus, very dilated umbilical vein entering in the coronary sinus, so a huge heart and sign of some effusion. And you see here the umbilical vein pulsations. And one more case of supraventricular tachycardia and regurgitation, tricuspid regurgitation, reverse ductus venosus, ascites, all features of congestive heart failure and umbilical vein pulsations, as you can see here. Some cardiac tumors, this is a compression, heart failure, yes, this is a rhabdomyoma, and this is a severe rhabdomyosarcoma infiltrative, and you see how huge is the heart and with some effusion. And here again, critical aortic stenosis, dysfunction, poor shortening fraction, and very, very short inflow with one single wave. This is a very bad critical aortic stenosis, too late to improve after aortic valvuloplasty. This is a case with huge ascites. And here, primary EFE of the right ventricle, you can see that there is no very bad contraction. And you see here pulmonary umbilical vein and ductus venosus with very abnormal patterns. And the last case, this is a hypertrophic obstructive cardiomyopathy, the same features in the Dopplers, and you see here very low septum priming excursion rate, as you can see here, and severe biventricular hypertrophy. So to treat, we have to go for the, look for the etiology. Some of them have treatment, like fetal anemia. You can make a intrauterine transfusion, twin-to-twin transfusion, TRAP, laser ablation. The tachyarrhythmias, you can use antiarrhythmic medication, myocardial dysfunction, AV valve regurgitation. One can think about using digoxin. The critical aortic stenosis, we can think about using, performing aortic valvuloplasty or atrial septostomy, and circular shunt. We have now been using indomethacin or ibuprofen to constrict the ductus and control the circular shunt. Just two cases of our experience. This is a medical treatment. This was a 20 weeks gestation, referred for fetal intervention because of critical AS. And we can see here that this baby had LV EFE, severely dilated, severe LV dysfunction, but there was a tiny aortic antegrade flow, but there was aortic regurgitation, which is not a feature of critical AS. There was pericardial effusion, fetal edema, polyhydramnios, reverse ductus venosus, and umbilical vein pulsations. These are some of the Dopplers, as you can see here, umbilical vein pulsation and reverse ductus venosus. And the final diagnosis was a primary EFE, was a cardiomyopathy, and they started digoxin 0.25 milligrams twice a day because there was nothing else to be done. And with 33 weeks gestation, no more high drops. You see the ductus venosus, but a very severe LV hypoplasia. So it was transformed in a hypoplastic left heart syndrome. At least the baby didn't die of high drops. And this is a case of a critical AS, very advanced presentation with gigantic left atrium and with high drops, as you can see here, ascites, pericardial effusion, and we performed aortic valvuloplasty. very well succeed. And here, 2 days after, there was no more pericardial effusion, and 1 month after, no signs of high drops. You can see that the function was very bad, still very bad, but the left atrium reduced a lot. And this baby was born and had borderline LV at birth. So we performed a hydro procedure, and at 5 months of age, you can see like the LV is improving systolic function. This baby had underwent biventricular conversion, and this is the left ventricle after all. So with the aortic valvuloplasty, the high drops was resolved, and she did very well. So to finalize my presentation, I would like to conclude with many physiological factors contribute to the fetus to be quite susceptible in developing congestive heart failure. A detailed fetal echocardiographic examination contribute to identify the underlying etiology. A complete cardiovascular assessment is key to establish the prognosis and the risk of fetal and neonatal demise. And the prompt identification of the etiology and disease state may lead to specific therapy that, although limited to some conditions, may change significantly the course of the disease. So with that, I thank you for your attention, and I'll be happy to answer questions at the end. Thank you.
Thank you very much, Simon. Beautiful wrap-up of heart failure, and actually some very new messages regarding the circular shunt and the use of endomethacin. And this is, I think, we could ask, I don't think we have any questions. Here, there's one for you about the cardiovascular profile score. Do you use the 10-point score, and is a 2 millimeter pericardial effusion considered -1 on that score? What is the cutoff for the physiologic pericardial effusion?
I think it's 2 millimeters, yeah. So pericardial effusion alone, less than 2 millimeters, there's no, I have no worries about that. But if we have the systolic, diastolic dysfunction, dilated heart plus pericardial effusion or ascites, then of course we will consider and anticipate that this baby is going to be in bad conditions and fetal high drops. And
I'm not sure if the effusion has anything to do with the score, actually. It's not part of, I'm not sure it's part of the score, is it?
It is, but not the size of it, but the presence of pericardial, pleural, ascites, yes. It's
okay. As part of hydrox assessment, yes.
Yeah.
But the pericardial sweat, the pericardial sweat is something that we really don't have to confuse it with a significant pericardial effusion,
yes,
right?
Exactly.
Okay. Thank you. And there's another question. Can you describe the M-mode method to assess heart rate and SVT?
Okay. So the M-mode should be, it's a good way to assess SVT, and we usually can do it concomitant atrial and ventricular contraction. So you have to put your cursor crossing atrial and ventricle concomitant, and then you can follow each contraction. In the SVT, they are 1-to-1, but very high heart rate. It's over 220, usually above 220 beats per minute. But in SVT, what you see is one ventricle, one atrium, one ventricle in very high heart rate.
One last question, and then we move. I think that's the TAPSI and MAPSI for diagnosis of systolic function in fetal life.
Yeah. So this is another technique that you can use. I think it's not very well established, the normal ranges, but I think when you use this kind of resources, you have to follow the fetals and look if it's improving and decreasing according to the time. So I think it's another feature that can be used. Of course, it evaluates this kind of the base contraction, base to apex movement, and I think it's another tool that we have nowadays.
It's very new, but there's no standardization. There are no references, right? Or there are?
Yeah. I think there are no big numbers, so it's another. I usually, when I follow the fetals, I think it's better to know if it's improving or decreasing.
Okay, I was told to stop, but for the next speaker, thank you very much. Thank you, Simon.
Can we get into global longitudinal strain, and what are the normal values and expectations for global longitudinal strains in Mali?
Yeah, I don't know exactly the numbers, but it's close to 15, 14.
The same as after birth then?
Yeah. It's close to the birth numbers, but not low, okay?
So anything above 15 is abnormal?
Above, it's normal. Minus 15.
So minus, it's minus. So it's a minus 12, minus 15?
Yeah, exactly. Above,
okay, minus.
It's abnormal. Yeah.
Thank you. Grace, you want to introduce the next speaker? Grace.
Hi, sorry.
Okay.
So the next speaker is as well a good friend of mine. So I need to acknowledge that, guys. So everybody from this webinar today is from Brazil. And I'm very, very proud to have all of them here with us today. So the next speaker is Claudia Castro Grau. She is the Director of Pediatric and Fetal Program at São Luís Hospital and Fleury Group, Coordinator of Fetal Cardiology and Echocardiography Program in Fleury Group, Staff Cardiologist at Heart Institute, University of São Paulo, where I did my fellowship, and PhD in Science from a University of São Paulo. And Claudinha is going to talk about diagnosis of fetal arrhythmias. Thank you, Claudia, for that.
Hello, everyone. It's a pleasure to be here. Thanks for the invitation. It's an honor. And congratulations for Congenital Heart Academy for amazing webinar. In a few minutes, I'll talk about diagnosis of fetal cardiac arrhythmia. That is a challenge for pediatric cardiology. I have no disclosures. Diagnosis of normal cardiac rhythm is based on the documentation of regular atrial and ventricular rhythm with normal heart rate for gestational age and AV conduction 1:1, which is atrial event followed by ventricular event within normal AV time. So how to evaluate fetal heart rhythm? Magnetocardiography is one method and it is limited used. Echocardiogram is furthermore used and it's performed by the simultaneous evaluation of atrial and ventricular contractions using M-mode, as you can see in this picture, atrial and ventricular contractions walls and the conduction 1:1. And pulsed Doppler, when you analyze the relationship between atrial and ventricular beats, the sample is placed between mitral valve and the aorta in four-chamber view, or 3 vessels aorta and superior vena cava, and in four-chamber view, the sample between the pulmonary artery and pulmonary vein. Tissue Doppler is another modality that allows the assessment of fetal cardiac rhythm, but I don't use it in my routine. The prevalence of cardiac arrhythmia in fetus is 1% to 2% of pregnancy. It is 10 to 20% of referrals for fetal echo. The most common cases are benign, and it's an important cause of non-immune hydropsis. Early detection prevents impaired pregnancies and hemodynamic consequences. There are three main groups: irregular cardiac rhythm, atrial premature contractions, and ventricular premature contractions. This is very rare. Tachyarrhythmia, heart rate higher than 108, such as supraventricular tachycardia, atrial flutter, ventricular tachycardia, and bradyarrhythmia, heart rate less than 100, such as first and second degree blocked, complete heart blocked, and blocked atrial bigeminy. In assessment of fetal cardiac rhythm, you should follow step by step, and we start evaluate atrial and ventricular rate, slow, normal, fast, and rhythm, regular or irregular. The AV ratio, 1:1, higher than 1:1 or less than 1:1. The relationship and time of atrial and ventricular events, normal AV time, prolonged AV time or AV dissociation, and duration, intermittent, sustained, or incessant. It's very important the assessment of the hemodynamic consequence, cardiac function, effusion, AV valve regurgitations, and fetal movement, the association of heart diseases, and the maternal and family story, long QT, connective tissue Doppler diseases, and grave disease. Premature atrial contraction, PEC, or ES, is defined as a premature beat, taking the previous beat as a ratio. Usually, it occurs due to ectopic beats. It may be isolated, frequent, or complex, conduct or non-conduct to the ventricle, blocked, and when is no conduct, there is an increased risk of supraventricular tachycardia. This a case at 28 weeks shows pulsar Doppler recording with a sample placed between mitral valve and aorta, and shows conduct and no conduct PAC, ESA across the ventricle, and we will observe that when the ECA is not conducted to the ventricle, you register a long pulse. Complex forms such as bigeminism and trigeminism is a form that increase the risk of supraventricular tachycardia, average 10%. This case is a very difficult case in my life, a fetus at 23 weeks with a bigeminism and trigeminism. This fetus had a mild pericardial effusion and ascites, and it progressed to supraventricular tachycardia, a very difficult control to the tachycardia, and need to high doses of sotalol. Irregular cardiac rhythm may be cause delayed ventricular beats. Blocked atrial bigeminism may lead to ventricular bradycardia. Atrial is irregular, and ventricular may be regular or irregular, and the differential diagnosis is with a second-degree block. This picture shows irregular atrial rate, correspond a blocked atrial bigeminy, and regular atrial rate that correspond second-degree blocked. Supraventricular tachycardia is most common type of tachycardia. Heart rate average 250 ppm. Hinterland mechanism is more frequent, and AV ratio is 1:1. It occurs due to the presence of accessory pathway. The electrical stimulus passes from the atrial to the ventricle through AV node and returns to the atrial to the accessory pathway in a circular movement. The hydrops and fetal death occurs in 35%, and it's considered an emergency. It's very important to evaluate to the AV and VA intervals. This picture shows normal EV and VA intervals, and in the other picture, you observe the short VA interval, and this short VA interval is common associated with hinterland tachycardia. This is a case, a fetus at 22 weeks. You observe the heart rate, a higher heart rate, and a short VA interval, and the diagnosis is hinterland supraventricular tachycardia. This is another case, shows MMO tracer, 1:1 conduction, a high heart rate, 258, and the diagnosis is supraventricular tachycardia. Although tachycardia may be well tolerated, if untreated, it causes low cardiac output and heart failure. This paper is very interesting and shows the increased risk of hydrops in fetus with a supraventricular tachycardia in compare to fetus with a congenital heart disease and cardiac tumors. Then, the assessment of the hemodynamic consequence is very important in fetus with a supraventricular tachycardia. You use the cardiovascular profile score, and a score of 10 is considered normal. Values less than 7 increase perinatal morbidity and mortality. And it's very important and relevant evaluate the ductus venous flow in the follow-up of fetus with tachyarrhythmia. Then it must always be included in evaluation. Abnormal ductus flow is strongly related to perinatal death in fetus with hydropsis. And when treatment, the supraventricular the supraventricular treatment restores cardiac function, and the ductus flows returns to the normal. This is a case at 6 weeks, supraventricular tachycardia, and sign of hemodynamic repercussion, a large aside. Atrial flutter is a type of tachyarrhythmia, and the mechanism is atrial hinterland circuit. It is 30% of fetal tachyarrhythmia, and it's most frequent in the third trimester. AV ratio may be 2:1, 3:1, or 4:1. 2:1 is more common. Atrial rate ranges from 350 to 500, and ventricular rate ranges from 120 to 330, according to the degree of atrioventricular blockade. Usually is incessant, and it's a serious form of tachyarrhythmia. This is a case, an example, a fetus at 26 weeks and atrial flutter, four-chamber view. You observe, and the diagnosis is due in the moment that you see. M mode, you check, and shows 2:1 AV conduction, 2A through 1 ventricle, and the diagnosis atrial flutter. Ventricular tachycardia is rare, 1% of fetal tachyarrhythmia. The mechanism increases ventricular automaticity. There is a atrioventricular dissociation with a ventricular rate higher than atrial, or 1:1 conduction, both with a high frequency. Etiology: idiopathic, longitudinal, and inflammation or tumors. This is only an example, M mode, and the diagnosis is ventricular tachycardia. Fetal bradycardia is defined by a heart rate less than 100, at least over a 10 minutes period. Occasional episodes are frequently solved in minutes. It's often observed in the second trimester, but it is prolonged or persistent. It's necessary to assess the cause. This is a picture. I love this diagram. It shows keys and pitfalls in diagnosis with bradycardia. I suggested you use it to guide the differential diagnosis of bradycardia. In the first degree AV block, there is a prolonged mechanical PR interval, and the second degree, some atrial beats with ventricles and some do not. Atrial heart rate is normal, and ventricular heart rate depends on the number of atrial conduct impulses. There are two types of atrioventricular blockade, second degree. Morbid type 1, PR interval prolongs prior to drop the ventricular beat, and in morbid 2, regular AA interval and AV dissociation. Complete heart blocked, it's a serious condition. There is a dissociation between atrial and ventricular contraction, no AV contraction. Atrial and ventricle beats are independent. Heart rate atrial higher than ventricular heart rate. The ventricular heart rate average from 6 to 7 ppm. The association with congenital heart disease in 50% of the cases, and is associated with cardiac tumors. In fetus, with pregnant woman with SSRO and SSB antibodies positive, the risk increase from 2% to 3%. Some parameters help us to preview good or bad prognosis. Ventricular heart rate higher than 55, atrial heart rate higher than 120. If out hydropsis and diagnosis at more advanced gestational age are parameters that preview a good prognosis. This is a case, 23 weeks, pregnant woman with a Jogan syndrome. As you can see, four-chamber view, a mild pericardial effusion, a mode record ventricular and atrial heart rate is very different. Heart rate, ventricular heart rate 55 and 109. Color Doppler in four-chamber view shows a tricuspid and a mitral regurgitation. This fetus at 27 weeks had a decrease in ventricular rate 46 and decided to introduce salbutamol and dexamethasone. The heart ventricular rate increased in 29 weeks and remain the same until delivery. Long QT syndrome is one cause of sudden death in children. This systematic review shows that some fetal factors may be increase the risk of long QT syndrome and help to identify identify this diagnosis. The factors are reduced baseline heart rate from 110 to 120, bradycardia less than 110 ppm, second-degree block, tachyarrhythmias, and clinical signs of heart failure, pericardial effusion, and hydropsis. Then the identification of these parameters may help to increase the perinatal diagnosis of long QT. In this case, a fetus, 24 weeks bradycardia and mother anti-Hall negative, referred to echo. The heart rate was 60 and atrial heart rate 120. In this moment, the diagnosis possible is AV blocked, but at 32 weeks, there was an increase in the heart rate, and the PR interval is normal. It's not common in AV blocked, and after birth, the diagnosis with long QT was confirmed. To conclude, the diagnosis and management of fetal arrhythmia is a challenge and crucial to improve outcomes. Premature atrial contractions are benign arrhythmias and do not require drug treatment. Please keep calm. Fetal tachycardias are an important cause of non-harmonic hydropsis and considered an emergency. Evaluation of cardiovascular score and venous duct flow should be included in cases of supraventricular tachycardia. Fetal bradycardia and AV block require long-term care and follow-up. And please don't forget about diagnosing long QT syndrome. I don't talk about the treatment because the time is very short for the presentation, but I'm available. Thank you for your attention.
Thank you very much. It's a beautiful talk and very, very important. And we have lots of questions, but I think we can ask one or two and then leave the rest of the questions to the end. One question says the follow-up. How often do you follow up patients with SVT after diagnosis?
You are muted, Claudinha. Yeah.
Can you hear me?
Yes.
Yeah, sure.
The follow-up of the SVT, I think I'm very conservative and I'm be careful. And when I have a case with SVT, I follow every 3 weeks, 3 days, and I increase the dose when I control, and I prefer control every 3 days that I had convection to the sinus rhythm.
Thank you. It's very important that that also what you said, picking up the premature atrial ectopics, that there is a chance that they can go into SVT. So what is the message with premature atrial ectopics? When would you tell the mother to come back? You don't want to lose them, because I think the setup is in Brazil is different from setup in different countries.
Yes, I think it's important. The differential diagnosis if non-conduct, conduct, and complex is different. When you have conduct and it's okay, I keep calm and keep calm every family, doctors, and I. And I recommend to take off symptomatic substance, and it's very important you control the mother stress.
If we have premature ectopics in the exam, Claudia, I mean, when would you say that there's a chance of this one to go to SVT? Somebody comes, we get a lot of,
1%.
irregularities, smoking or so on. So how would you counsel the mother with this? Yeah.
Okay, 1 to 3% if conduct or no complex. If complex, bigeminalism, trigeminalism, some studies show up to 10%.
Okay. I see here we have the master of all trades, Dr. Silverman. Do you have any questions? No? And we have Dr. Anita Moon-Grady as well. Anita, do you have any questions? Do you have any comments? Because we want to use all those important people to educate ourselves with their advice and so on. If we don't have any questions, yeah.
Sorry, breaking. I can't hear. Sorry. It's
no problem. No problem. No problem.
I do have a question.
Okay.
I do have a question, Rima. This is Anita Moon-Grady from UCSF. I joined a bit late, so I apologize if this was covered. But with the patients with supraventricular tachycardia who are being treated, what is your approach to weaning the medication? Say atrial flutter has converted, or reentrant SVT has converted on, let's say, 2 different medications. Do you wean, and do you use any home Doppler measurement to help guide that?
Okay. The first line to the treatment of SVT and atrial flutter is in Brazil. I don't have flecainide. Then I have digoxin and sotalol. Both is the first in the atrial flutter. Sotalol is the best, but in my experience, I prefer sotalol. I have a good result. I don't have side effects in mother. I have easier control. Every 3 days, I do ECG to control QT interval, and I think it's good. But many centers in Brazil use digoxin to the mother. It's very, very particular. At my hospital that I am director, I use sotalol in both.
Claudia, she's asked, Dr. Moon-Grady is asking, is there a protocol of weaning? So if the patient comes and then you're back to sinus rhythm and using 60 milligrams or 80 milligrams 3 times a day, what will be the protocol of weaning once you go to sinus rhythm?
Okay, I started with 8, and I increase every 2 or 3 days. The initial dose is 160, and in some cases, if I saw that the bigeminalism and trigeminalism of fetus at 22 weeks, I need to increase 440. is a high dose to control. It's very difficult to control. And in this case, I associate the digoxin in 2 days, but the fetus has a long pulse and I need to take off. But in my protocol, I start 8 and I increase 404.
And when the fetus is on sinus, do you reduce the dose or you leave
yes,
like that?
Yeah, no. I reduce. At home. I control at home, and I reduce. And some case, I think all cases delivery 108 or 200, and it's okay. It's okay.
Do you keep doing regular ECGs part of the protocol to the mothers? Do you keep doing regular ECGs on the protocol?
Yes. Every 3 days. 3 days.
Okay. Beautiful. Dr. Silverman, we want to. Dr. Silverman, one question.
Sorry, I still don't get an answer from Dr. Grady, from Dr. Grady's question. You have a fetus who's you've treated is in sinus rhythm. Do you maintain them on a given dose, or do you wean the dose of your medications, and how do you do that? Perhaps, Anita, you could tell us what the UC policy is on that.
Norman, thank you. We are participating in the randomized controlled trial, as are probably a lot of people on this call. And if you're not participating, please do participate, because we need more patients. And it's an international study of flecainide versus digoxin for first-line therapy, and for flecainide plus digoxin versus sotalol plus digoxin for hydropic fetuses. And so because we're enrolling in the study, I've been very careful to use care maps. Outside of the study, we would, now that we've got a lot of experience with home monitoring, home Doppler monitoring, we would probably try to wean to single agent therapy if the fetus is initially controlled on more than one agent. And for atrial flutter, I think it's possible to wean all the way off during the pregnancy, although I have not done that yet. For the reentrant types of SVT, I would keep the patient on at least one medication through the rest of the pregnancy, probably either digoxin or I do like sotalol, although right now the randomization scheme would be to flecainide. But maybe reduce the dose a little bit with home monitoring, home Doppler monitoring by the mother.
Me too. I reduce the dose home, and I reduce I control, and I reduce to 200 and or 108 to delivery.
Anita, not everybody knows about the Doppler home monitoring. Could you please tell us more about that?
No. I control in my hospital. I ask for a mother to go every week for my exam, and in such situations, I ask to go every 3 days.
This is the usual, but in the US, they are sort of dispensing, and I'm not sure if in Europe, kits for mothers to check their fetus heart rates. Anita, could you please tell us more on that?
Yeah, you can. They actually are, most of them FDA approved, and patients can buy them on Amazon or their other, online option of choice for anywhere from $35 to $75. A little Doppler monitor, handheld monitor, usually battery powered, that they can hook up to their iPhone or hook up to other headphones. And it's just Doppler, so we give them, we have a bunch of these that we have purchased over the years, and we loan them to the patients, or we give them the option to buy their own. And they check twice a day, sometimes 3 times a day, but twice a day. And if they hear anything unusual, they are to call and to come in to be seen. We're using them more for the SSA patients to try to detect heart block sooner, but it's useful to have some of these monitors in your clinic. We can't charge for this service. It's really just trying to do the right thing for the patients, but it's pretty easy to teach them. And after about 18, 19 weeks, the mothers are pretty good at finding the fetus.
So simply you are trying to teach mothers to, with a prolonged PR interval, to check the complete heart block in a way. So how are you asking them to, where do they put the Doppler? I mean, just on the tummy and I attended the talk by somebody else also. I think this has made a big difference in cases of early detection of heart block by home monitoring.
Yes, I follow 18 weeks at 26 week. I follow the PR interval. If it's established, it's regular. I follow every week, and if it's stable, I follow every 2 weeks. But if the PR increase or is more than 140, 50, I follow, I maintain follow every week.
Thank you. Thank you very much. Thank you.
Let's move forward.
Grace, you want to introduce the next speaker? Sorry?
Yes.
Grace?
Yeah, I'm not muted. Very good. So the next and last speaker, and after her talk, we are going to have more questions. So guys, please stay with us. So is Dr. Marina, a good friend of mine, and I'm very happy to have her here. So Dr. Marina Zamit is the director of fetal and pediatric echocardiography at Hospital Santa Joana in São Paulo, Brazil, and is the coordinator of the postgraduate course in fetal echocardiography at CETRUS, and is PhD in science at Federal University of São Paulo, and she's going to show us challenging cases. Thank you, Marina.
Hi, everyone. I'd like to thank the Congenital Heart Academy, Sasha, Gil, Grace, and the course organizer, Dr. Hima Bader, for the invitation to be a speaker in this fetal series. And I'm very glad to be here among colleagues and friends. My talk today is about challenging case of congenital heart defect for diagnosis in fetal life. I have no disclosure. And what is a challenging case of congenital heart disease? Well, there are many when we're trying to diagnose them in fetal life. Difficulties to be certain of the diagnosis when even with simple heart defects due to fetal circulation, such as coarctation of the aorta, or due to complexity of congenital heart defect, like double outlet right ventricle, anomalous pulmonary vein drainage, AP window. But her case are challenging as well, something you never seen before. So it's good to see it once. So I brought 2 of these cases to discuss with you today. The first case is a second gestation of a 20-year-old mother referred to fetal echo for abnormal 4-chamber view in the ultrasound without any significant medical condition or family history. The fetal echo was performed at 26-week gestation. The fetus position was cephalic, the back to the right. So as usually, we first define the left and right side of the fetus. So here the left side is up and right side is down, and the situs was solitus. Moving to the chest, we see the heart and apex to the right, and it's quite difficult to see the two atria, the interatrial septum, but we can see two ventricles, a large VSD, and maybe only one atrioventricular valve here. We're not able to obtain a good four-chamber view at standard transverse plane. Instead, we could identify a more or less four-chamber-like view in a sagittal plane of the fetal chest, but we can't see the parallel atrium and ventricle as we are habituated to see. With further movements, we identify the two atria, the interatrial septum, and let's stop for a while and check the topology of the structures and what we have so far. The morphologically left ventricle is on the right, and the morphologically right ventricle, as we clearly see here, the moderator band is to the left. And as we have a situs solitus, the atria are correct. Left atrium to the left, right atrium to the right. And what about the AV connection? As we move on, that initial impression of a common AV valve seems to be wrong. Maybe an atresia or the left AV component, but it wasn't possible to show the parallel alignment of atria and inlet. But in fact, we have two AV valves crossing. Let's see a little bit slowly here. To image the AV connection, we tilt the probe and swept carefully from posterior inferior to anterior superior direction in order to visualize this twisted spatial relationship of the AV valves, which are not in parallel, but they are crossing each other. So this is a crisscross heart. So the connections are concordant. The left atrium connects to the right and inferior left ventricle. Here we see the color Doppler study clearly demonstrate the blood flow direction from left posterior to right inferior. The right atrium connects to the anterior right ventricle, which is to the left, and superior relative to the left ventricle. Here we see the tricuspid valve with thickening leaflets and reduced diastolic opening. In this image, we can identify the flow to the VSD, which goes in only one direction from the left to the right ventricle. And that's because both arteries arise from the right ventricle. Here you can appreciate the pulmonary artery posterior and the aorta anterior in a transposition mode. The color Doppler study shows a turbulent flow in the pulmonary artery with high velocity. So we have a pulmonary stenosis as well. The baby was born by normal delivery in good condition without the need for procedures. And this is the current echo at 1 year and 9 months. These are images from the subcostal view. I think the best one to show all this particular spatial relationship. On top right, we can see again the dextrocardia and Bolzania and anostium secundum communication. Here we see the left atrium, left ventricle connection. We can clearly see the topology of the left ventricle and the interventricular septum in a horizontal position. In bottom right image, the right atrium connects to the right ventricle and the dysplastic tricuspid valve. Both arteries arising from the right ventricle. Here we see the pulmonary stenosis with a gradient of 100 millimeters of mercury. The crisscross heart is a rare congenital heart disease, and it was first described by Lev and Howlett in 1961. But it was only in 1974 that Professor Anderson and Professor Scheinborn first used the term crisscross heart. And an update was described in 1982, suggesting a better definition. And as the author said, in fact, there is nothing paradoxical about the AV concordance or discordance. The crisscross is a rotational abnormality of the ventricular mass, so that the relationship of the ventricular chambers are not as anticipated for the given atrioventricular connection. In crisscross, while the base of the heart remains unchanged in its spatial position, the ventricles appear to have been twisted along their longitudinal axis. And as I have already stated in our case, the keys for diagnosis are the inability to obtain a four-chamber view at standard transverse plane. The four-chamber-like view is seen better in the sagittal plane of the fetal chest. The AV connections are not aligned. The interventricular septum has a spiraling orientation, and the orientation of the two ventricular inlets is more in a superior-inferior and crossing position. Usually the situs is solitus, but there are cases of situs inversus and isomerism. Usually the concordant AV connection, probably because the ventricles rotated clockwise, but if they rotate in counterclockwise, it can be discordant as well. So the more usually is a concordant AV connection. The ventricles in superinferior position may not be present. Actually, papers with CT or MRI studies have demonstrated that a more near vertical position is more common than a true or horizontal orientation. The common lesions associated are VSD, double outlet right ventricle, TGA, pulmonary or subpulmonary stenosis or atresia, and tricuspid hypoplasia. So our case is a rare but a typical one. Let's move to the second case. Next case is a 30-year-old mother, second gestation, no history of previous disease, referred for fetal echo for presenting a cystic and pulsatile image in the abdomen of the fetus in routine ultrasound. These images are from 25 weeks gestation. Here you can appreciate a sweeping from the fetal abdomen towards the chest. Here you can see the cystic mass. The situs was solitous. The fetal heart anatomy and function were normal. In the historical abdominal sagittal view, we identified the saccular pulsatile mass in the fetal abdomen that measured 20 by 18 millimeters. With scalar Doppler study, we can see the end of thoracic aorta, and proximal to the diaphragm level, we identify a turbulent flow and a second saccular dilatation connecting to the large one. So it's an abdominal aortic aneurysm. There was no family history of connective tissue syndrome, such the most frequent Marfan or Ehlers-Danlos. Only the mother's grandmother had an aortic aneurysm, but with 60 years old. Analyzing the entire path of the aorta, actually, we have a multisaccular aneurysm, but not compromising the renal arteries or the iliac arteries. Sorry, here the iliac arteries. At 27 weeks gestation, the aneurysm did not progress. The velocity in that narrow region with turbulent flow was high, 20.5 meters per second. But there was a normal heart function, as we see here, the TAPSE and the left ventricle index within the normal range. But 1 week later, we observed a cardiomegaly, biventricular hypertrophy, moderate mitral regurgitation, and a deteriorate ventricular function. The aortic valve, ascending thoracic aorta, remains normal. Progressive worsening culminated in fetal death at 30 weeks, and no pathological study could be realized as the parents didn't consent with postmortem examination. The congenital aortic aneurysm is an extremely rare condition. Few cases described in the literature, less than 40 in neonates and infants, and it could be associated with infection, vasculitis. In connective tissue disorder, few cases describe the localization in the aortic root or thoracic aorta. The iatrogenic trauma, such as umbilical catheterization, may be a cause in the neonate. But prenatally, as we are aware, there are only about 9 cases described. The most common localization in abdominal aneurysm is infrarenal, 69%. Less common, thoraco-abdominal. The majority without definition of etiology. We found one similar case to ours in the literature by the group of fetal medicine from University of Texas, and Dr. Alissa Carver kindly sent us this image to share to you all. We can see here the multisaccular aneurysm, the measurements a little bit smaller at this point than our case. Here is color Doppler. The baby was born at 40 weeks. This is the postnatal echo, and the dimensions now is very similar to our case, about 20 millimeters. The TC shows beautifully the region of coarctation, 2.5 millimeters below the celiac trunk. The aortic dilatation extended to both iliac arteries, and the neonate developed biventricular hypertrophy. And with 2 months underwent the surgery with aortic biliac reconstruction and reimplantation of the left renal artery. But in the second day post-op became anuric and the family elected to withdraw support. Autopsy was declined by the family. The aortic aneurysm is probably the result of a developmental arrest occurring along the arterial system in the late stage of embryogenesis. The pathological studies reveals loss of elastic fibers in the aneurysm wall, marked fibrous proliferation of intima, and gradual transition to media. And the evolution depends on the extension, presence of coarctation, and intrauterus heart failure. We do presume that in our case, the coarctation was an issue in the fetal heart deterioration. I hope you enjoyed this presentation, and I'd like to thank all my team of fellows and colleagues, in special Dr. Juliana Novaes and Dr. Cristina Rizzi, who helped me with the image and the case. And I will be glad to answer any questions you may have. Thank you.
Thank you very, very much. Really, really interesting cases. The last one, I think Dr. Silverman is not really wasting any time to ask questions about the last case. Dr. Silverman, abdominal aneurysm in a fetus, probably you've seen a lot of that.
Marina, that was spectacular, spectacular. I mean, to have got everything on that first case, twisted atrioventricular connections. We call them twisted rather than crisscross. And the reason is that this is Professor Anderson's description, is that the twist occurs after embryogenesis is completed. And I've noticed that in the rare cases that I've seen, that there is also malposition of the great vessels. So when there's transposition, for example, it's SDL, the aorta is also twisted around to the left side. Have you noticed that as well?
Yes, in this case, thank you very much, Professor Silverman, for your comments. And I have only 2-3 cases of particular. It's strange because after this one, I have seen another 1 month and never more. Just these two. And in this case, it's a SDL, I think, the composition of the great arteries. Yeah. Yes, I think it is, yes. And the other one is a similar case with double outlet right ventricle. I think in my experience of 2 cases, the most common.
I've also seen that in double outlet right ventricle.
Yes. Yeah.
But I think that looking at the atrioventricular connections is so critical. And I think you did that so very well for the panelists. I'm really quite outstanding. And your research on this is spectacular. And we go back and we see that nothing is new. And that Dr. Rolat and Dr. Lev had described this already again in the 1950s.
Yes.
So thank you very much for that.
So what is the stimulus, Dr. Silverman? Why does this happen? This upstairs, downstairs heart, or crisscross heart, or twisted hearts? What is the stimulus in utero, embryologically?
Upstairs, downstairs heart is a different entity, but the twisting occurs after embryogenesis. We don't know why it occurs, but the twist keeps the atrioventricular connections are the same, and as the upstairs downstairs heart, it goes from the right atrium to the right ventricle, which is usually the superior chamber, and it comes from the left atrium to the inferior left ventricle, and the atrioventricular connections cross each other, and there's usually a ventricular septal defect in these conditions. I've only really examined one heart with crisscross connections. It's now in the collection of the cardiac registry in Boston. And in that patient, there was, the heart looked more like a congenitally corrected transposition when you looked at the outflow part of the ventricles, but the inlet part of the ventricles with its large ventricular septal defect clearly showed that the left atrium connected to the morphologically left ventricle. and the right atrium connected to the morphologically left ventricle with superior and inferior relations of the right ventricle.
So I'm sorry, I made a mistake. So crisscross is different from upstairs, downstairs.
Well, you can get upstairs, you can get to crisscross in an upstairs, downstairs relationship. You can get it. But I mean, for example, single ventricles may have a crisscross relationship. But this is a true, I think, separate entity with the atrioventricular connections cross each other. And they often cross across a VSD, which makes it even more complicated to understand. But your question, Dr. Bader, relates to when does it occur? And it's clear from the embryology that this is a post normality of the heart. When the heart is developed, there is some form of twisting that occurs within development that brings this entity into its position.
Thank you very much. But the second case, what's your comment, Dr. Silverman, this abdominal aneurysm? And I was wondering, the real cause of death here, is it the steel or what is it? The heart failure, uncontrolled, why? And is it the usual end of the story that they die in utero? I expect so.
Well, I mean, I think that there's the authority is Marina. Marina knows this. So for me to comment on this would be difficult.
No, both of you. I'm sure you've seen a lot as well, but to get double dose.
High output cardiac failures, and this is a high output cardiac failure syndrome because there's a tremendous AV malformations, and in all AV malformations, we can go back to Simone and ask her about this. But high output, and Dr. Moon Grady is an authority on this, and she's here. So I would think that I should shut up, and we should get Simone and Anita to give us their opinions on this.
I would appreciate, because I really don't know what happened. I was thinking that maybe this postductal coarctation, I thought, but it's not common to see things like this. And the case that Alyssa Carver sent, it is the same one with the same coarctation, and there is not a dysfunction. So I would appreciate your comments.
No, I can only talk about sacrococcygeal teratomas, and that high output is often associated with death. I think that there's now an opportunity to do laser coagulation of the sacrococcygeal teratoma, but in my own experience, this was not possible, and there certainly was associated with progressive increase in cardiac output to almost twice, or in fact, even greater than twice the normal cardiac output. We were getting 1,200 cardiac outputs of 1,200 mils per minute per meter squared of body surface area, which is way, way, way above normal. Normal is between 450 and 550 mil per minute per kilogram. And
would you be able to treat? Would you like to treat in utero? I mean, in 2021, would you treat in utero? I mean, for heart failure. I'm not talking about sacrococcygeal teratoma. For the abdomen, for the abdominal aneurysm, would we treat? Will it make a difference?
Yes. But why don't you ask Simone for an authoritative comment?
Simone and Anita and Marina, would you treat?
Teratoma. A teratoma, you mean?
You have to unmute. Yeah. Would you treat like heart failure with digoxin? Did in one of the cases where the score improved a little bit? Would you treat heart failure with abdominal aneurysm in utero? Would you try to see?
Well, I've never seen something like this abdominal aortic aneurysm. And I wouldn't start any medication because, it's something that you have no idea what's going on and why it happened. Regarding teratomas and fistulas. If it's possible, I would treat, not myself. I'll call Fabio, who is the fetal specialist, and he knows exactly if it's possible or not, depending on the situation. But this fetal aneurysm, I don't know anything about that. It's the first time I've seen that. So it's an amazing case. And I have no. Let's ask
one
Anita.
more one question. Let's go to the audience because we have only 10 more minutes. Simone, to you, choose modified thigh index measured by tissue Doppler method to assess RV function from Yezuku Mino.
No, I prefer to use the Doppler, regular Doppler, not the tissue Doppler in the fetal life, because it's not very accurate, not very, clear. And I think the measurements, we always make mistakes with measurements if they are not very well acquired, like the Doppler. So I prefer to do T index using the regular Doppler, not the tissue Doppler.
Claudia and Marina and Anita, what do you think? Any answer to the question?
No, me too.
Would you use the usual?
Can I make a comment?
No, I usually regular Doppler. I prefer.
Yeah. Can I make a comment?
Anita? Sure.
Go ahead, Norman.
After you, Anita. Ladies first.
I'm not quite sure which question to answer. I think that there's a fundamental difference between an aortic aneurysm and these arteriovenous malformations, including sacrococcygeal teratoma. Norman is quite correct and published actually this observation that 2 or even 3 times the normal cardiac output, combined ventricular output, is tolerated, but beyond that, they become hydropic. I think that, there's a very high preload, but very low afterload when there is a large sacrococcygeal teratoma. And I think that facilitates this ability to tolerate this huge shunt. So I have never seen an abdominal aneurysm like this, and I don't, all I can say is I don't think that in and of itself is enough to cause a high output type of failure. Maybe this aneurysm is only the echo manifestation of a systemic disease. But I thought that was fascinating. There are also, just in the differential, there are a couple of case reports of abdominal AV fistulae between the celiac axis and the hepatic veins, for instance, and those may be amenable to invasive therapy. The other therapy that you can try, is digoxin. It may improve your cardiovascular profile score by 1 or 2 points, which might be enough to get the baby, big enough to deliver for some definitive therapy. So if there's no invasive option, then I would probably try digoxin or early delivery for any fetus with high output failure.
Anita?
Thank you.
I agree. There's just one question for you, Simone. One of the issues about all of our measurements, and I think you are also skeptical about measurements, is that the measurements are really very good when the disease is very obvious. So if you've got profound cardiac failure, it's very easy to use any of these intervals, including the eyeball. But when you get closer to normality, where you would want to look at the declining from normality, early decline from normality of cardiac performance, that this becomes very difficult with all measurements. So this really puts us in the usual dilemma for making these assessments, is that when we really need them, they don't really help us that much. And when we don't need them, they're perfect.
Yeah, I agree completely with you. And when I have such a situation, well, is it normal, or is close, or it's being a normal, is turning to an abnormal? I would try many of them. You know, I would do as many as how do I say? Parameters as I can, like MAPSI, Simpsons. If I have strain, I would do. And so, because I agree with you, it's so, you have to be very critical when you do perform a measurement and to say, oh, this is different from normal, this is normal. So I think eyeballing, and I tell this to my fellows, first of all, this measurement has to be concordant to your eyeballing. What do you think?
Yes, yes.
Do you think that this is normal or abnormal? And then you start doing the measurements. Because
absolutely,
I care for so many measurements that doesn't tell the truth. So I think we have to take advantage of the measurements, but we have to be very critical with them. How to perform them? You have to zoom the heart to reduce.
Simone, yeah, I think
I think your connection is bad, Sima. You are breaking. Can you say it again?
Yes. I lost you.
Regarding the measurements, this is very, very important. So can we all help each other and help the audience? I think the most difficult measurement, that to me at least, where you need to take action, is the M mode for arrhythmias. Now, the trick, I think, is I'll listen, and I think the master is Dr. Silverman. Where you put the heart, how you put your box, where you put the filter. I think, can someone summarize this, so that, because I personally depend on Doppler more than M mode, but I do both. But I think we can make mistakes. I can certainly make mistakes if the filter and the focus are not up to the. So can we all help each other, help the audience, tell them how to obtain a proper M mode in case of arrhythmia?
Who is going to answer that? I can answer. I don't know if you have tried the Voluson equipment, but this is very nice because you can take one sweep, one
any plane,
and then you put your cursor wherever you want. Together, atrioventricular. So this is the new technology that helps a lot. But not everyone has this kind of machine everywhere available. So I think this is challenging to put very good tracing of the atrial contraction and the ventricular contraction. So I try to change the position of my transducer to put them in a very I would say parallel to the transducer, to the cursor, to have good tracings. But if you have the Voluson equipment, you can just take a cycle, in a clip, and then you put the cursor at wherever you want to. And that's very, very nice.
I think that's great, but the difference, I'm an old guy, I'm probably the oldest person on the panel here, but the thing about M mode is that the normal M mode, even in a phased array system, has a cycle frequency of 1,000 cycles per second. The Voluson is limited by the frame rate of the system. So it's less precise than the old-fashioned M mode, and I'm still a believer in that. And in fact, the timing precision of M mode is much greater than Doppler, because remember, the Doppler is an envelope that we're looking at, which is a fast Fourier transform, which doesn't have actually exactly precise measurements. They're pretty good, but they're not so precise. So if you want to argue about timing, I would suggest and submit that timing is much more accurate with M-mode echocardiography than it is with a pulse Doppler. But obviously, we would use both. And I hope that's a good enough answer for you, because I have one question and a comment for Simone, and that's related to the work that we started looking at with the relationship between systolic and diastolic flow within the cardiac cycle. And the flow within the cardiac cycle is like two bedfellows. If one bedfellow is occupying a large part of the bed, only a small part is available for the other bedfellow. So for example, as if systole prolongs, diastole will shorten. When filling prolongs, emptying will shorten, and vice versa. So we've been looking at the duration of the A wave in heart failure, and I wonder, Simone, whether you've looked at that. We call it a systolic diastolic ratio, and whether you've had any experience with this, or have had any value from this particular measurement.
No, I have no experience with that. Sorry.
It's very simple, because all you need to do is measure the duration of the A wave and compare that to the RR interval, however you want to measure that.
Yeah.
And
yeah.
subtract the one from the other, the ratio. Yeah. I would encourage people to look at that.
Norman, that ratio is a bit heart rate dependent, though, is it not?
It is heart rate dependent, but the way the curve looks, it looks like when you get up to 100, anything under 160 is useful.
Mm-hmm. And of course, since you trained me, I do use this. Even if Simone doesn't, and we've shown, and there have been at least another couple of papers on this, that this is a very easy measurement to make, and it is clearly abnormal in patients with hypoplastic left heart syndrome and twin transfusion. So it's a good global index of right ventricular function if you're otherwise having trouble assessing the right ventricular function in particular. I also just want to put in a plug for tissue Doppler. We did do a study several years ago now, comparing head-to-head the pulse wave Doppler method of measuring the myocardial performance index in the right ventricle with lateral tricuspid annulus tissue Doppler. And at least in our hands, the inter and intra observer variability was less, and the sensitivity was better for picking up mild abnormalities, and in this case, it was diabetics. So unfortunately, we bought a new machine, and so all of our validation of the tissue Doppler measurements kind of went out the window. But it's just a thought that that if you can learn to do the lateral tricuspid annulus tissue Doppler for measuring your PR intervals for your SSA patients, that you might consider following changes in myocardial performance index by tissue Doppler, because it can be better than the pulse wave Doppler.
Anita, do you compare? I mean, did you compare both methods in your paper?
Yeah, that was the point of the paper, was to compare the two.
Can we read it, because it's beautiful? I mean, I think we'll add it to the old.
Yeah.
Okay.
I can email you I'll email you the link or the reference.
Very good. Dr. Silverman, do you want to choose one last question from the Q&A chat box so we can wrap up?
I haven't been looking at the chat box. Maybe you can look at something. I've seen lots of thanks.
Yes, this is because fetal cardiology, I'm learning a lot. This is not my field at all. So I just can't find a very interesting question. If any of you of the panelists can comment. Yes, Gustavo, please.
Just a comment. I'm concerned that we have actually, and all of them is to improve the fetal diagnosis. In the matter of the practical approach, I think it's important when we came across a postnatal diagnosis, we track it back to the operator, doctor, sonographer that did the fetal echo. So we'll be able to together learn and improve our detection rate of congenital heart disease. And as we know, it's important to improve it. And I give an example, the European Surveillance of Congenital Anomalies, the EuroCat, between 2010 and 2015, they described that TGA hasn't prenatal diagnosis in more than 35 of cases. And as an example that I showed to the audience in the last slide, the 3VT isn't there on TGA, but sometimes it appears. And TGA, compared with some major multisystemic defects, is one of the last detected. And the good news is that we are getting better. In the early century, the same society described that was less than 50%, and now 35%. And something that we have in mind, and all of us work together, and this audience, big audience around the world, I think something important thing.
This is very nice. We saw on the chat box a lot of people who are starting actually their fetal program. So this is something that is very interesting for them, as well as they are starting their experience, should take a look back if they misdiagnose something, how to learn from that. Thank you, Gustavo.
Yeah, one more question. Jason Tan asked about the cardiothoracic ratio. Simone, how do you measure it? Are you using an area method, a circumference method? Which method are you using? And does it matter if you use one or the other methods?
You can use both, depends what it's easier for you and about the picture. And it doesn't matter, you have to know that inside the thorax, in a very axial image, you should have 3 little hearts. And if you can put 3 there, there's something wrong, so the heart is big. And you can measure each way. I don't think that there is any difference in that, but you have to know when it's bigger than it should be or smaller in some cases because of compressions. So I usually do the diameters because it's easier. And I don't care much about numbers, except if I'm putting in any study or any score or things like that. So you can
also in this case, we have to get a view of chest of short axis. And a good tip is when you get an entire coastal arch, that you make sure that you are on transverse plane, and there you're gonna get a good accurate CTR.
So the usual is 1/3 of the cross section, the heart. If it is higher than that, this is not normal, right? Basically,
yes.
Yeah.
Also, sometimes the heart can be very small in constrictions.
Yes.
There is a normal limit, and why I like the data from England is that there is a percentiles for this, and it changes throughout gestation. Palladini is the author's name that did those measurements. That's the only reason I like it, because I can go and look at where it is on a chart. So one important question for Claudio is that if you have one child with heart block, what is the risk for a second or a third child with heart block?
If mother has anti-Ho positive, the second the risk increase 18%. The second.
And the third one?
Yes. Yeah. The third I know. The third I don't know. The third I don't know. I know that the second baby, the risk is 18%. If the first has a complete heart block.
Okay. Well, thank you very much for that. The thing that always strikes me about lupus is that there is a infertility in lupus syndrome, and yet they provide us with a huge number of patients for our assessment. So obviously,
I'm not sure of the 80%. I'm not sure.
Read the textbooks.
Normal, and Claudia, I'm not sure of the 80%. I think it's 20, but for the second one, it also depends on the etiology.
20%.
I have a paper that describes 18% in the second baby that the mother has anti-Ho positive.
Oh, okay. So 80. That's interesting.
Mark Twain used to say
1-8, right?
Oh, 1-8. Oh, okay.
1-8.
That's
18.
Yes.
18.
Mark
18.
Twain
That's okay. That's fine.
Almost 20.
18.
Almost 20. Exactly.
Almost 20.
No.
Sorry, I heard it 80. I'm sorry. Yeah.
No, 18.
You know, as Mark Twain used to say about statistics, what we call good, better, best, or bad, worse, worst, he would to say that there are lies, damn lies, and statistics. And I think the difference between 18 and 20% is in that range. I mean, it doesn't really matter whether it's 18 or 20%. You know, you've got about 1/5 of the patients who are liable to have a recurrence. And whether it's 18 or 20% is of no consequence.
Yes.
It's beautiful. I think we should thank all speakers. Really, I mean, we would all like to go to Brazil once the corona is over and enjoy enjoy the weather there.
Already.
Yeah, and also
I've got my passport is in my hand, waiting to come to Brazil again.
You have to take the vaccine first. And just to summarize, we did speak about the basics here, and also with Dr. Staven, and then we went into the function, and then we went into arrhythmia, and then we went into beautiful cases. So we went on 3 levels, from basic to intermediate to advanced case of fetal. And this is, I think, the message here is that we keep learning, we keep teaching ourselves, attending seminars, and thank you again for the Congenital Heart Academy for putting this in action. From all over the world, people come and talk and learn together. And I'd like to thank also Grace for a beautiful effort to get her own people to talk and teach the world what they do in Brazil. I'd like to thank Dr. Silverman, who is the master of all trades, and we all learn from him, and also Sasha and our guests, Anita and Ulrika Herberg. Thank you so much.
And one last thing, and that's for all of the participants that are listening here, this is recorded on the HeartTube channel, and I think maybe Grace could put that up for everybody, because one of the important issues of all of these meetings is the information is so intense that you need to go back and look at it again. I do this on every one of the sessions, and sometimes more than once. So I would certainly recommend that to everybody over here. Thank you.
Thank you very much, guys. And please share the link of our Congenital Heart Academy YouTube channel with your colleagues and with your teams if you found this webinar interesting, so more people can learn. Thank you, guys. It was amazing. Thank you, Dr. Anita. Thank you, Ulrika, and thank you, Rima. And it was amazing. And thank you, my people. So proud of you. It was amazing.
Yeah, great.
Thank you. Bye-bye.
Bye-bye. Thank you very much.
Bye-bye.
Bye, guys.